Welcome to the series where I'll be discussing the 2026 Consensus Statement on the Algorithm for Management of Adults with Type 2 Diabetes by ACE. This is Endo in a Bite, where I break down endocrine concepts or lengthy guidelines into focused, high-yield pieces you can actually remember. For the full board-centric framework, I've built it all out in easy endo prep, designed to keep you efficient, current, exam-ready, and sharp in clinic. Visit www.ezendoprep.com to enroll in the full course or start your free trial. This is the third and final episode reviewing the 2026 ACE approach to insulin management in adults with type 2 diabetes. In the first two episodes, we reviewed glycemic targets: when to start insulin, basal insulin initiation, basal titration, once-weekly insulin, and overbasalization. In this episode, we will focus on prandial insulin, basal bolus therapy, prandial titration, hypoglycemia management, glucagon, and premixed insulin. Let's begin with the transition beyond basal insulin. Basal insulin primarily targets fasting hyperglycemia. When fasting glucose is at target, but post-meal glucose remains above 180, continuing to increase basal insulin may lead to hypoglycemia without correcting the main problem. A basal dose greater than 0.5 units per kilogram per day or a beam score greater than 50 milligrams per deciliter should also prompt evaluation for overbasalization. The beam score is bedtime glucose minus morning pre-breakfast glucose. When this pattern suggests persistent post-meal hyperglycemia, consider adding prandial insulin. Rapid-acting insulin analogs are preferred to regular insulin. Prandial insulin does not have to be started before every meal at the same time. A stepwise approach is often appropriate. Begin with the largest meal or the meal associated with the greatest glucose excursion. Start with 5 units or approximately 10% of the basal insulin dose. If glycemic goals remain unmet, add mealtime insulin before a second meal and then before a third meal as needed. Some patients will ultimately require a complete basal bolus regimen. A common starting framework is approximately 50% of the total daily insulin dose as basal insulin and approximately 50% as prandial insulin divided across meals. The final distribution should reflect the patient's glucose pattern, meals, hypoglycemia risk, comorbidities, and treatment burden. Prandial insulin can generally be adjusted every 2 to 3 days according to the glucose pattern and the individualized target. The key is to adjust the insulin dose responsible for the subsequent glucose reading. When adjusting mealtime insulin, use the glucose level before the next meal to guide the dose. If the glucose before lunch is above the individualized target, increase the breakfast insulin by about 10 to 20%. If the glucose before dinner is above target, increase the lunch insulin by about 10 to 20%. And if the bedtime glucose is above target, increase the dinner insulin by about 10 to 20%. Breakfast insulin is therefore assessed using the pre-lunch glucose. Lunch insulin is assessed using the pre-dinner glucose. Dinner insulin is assessed using the bedtime glucose. Do not increase every prandial dose simply because the A1C is elevated. Identify the time of day when glucose is above target and adjust the dose associated with that pattern. The same principle applies to hypoglycemia. If the pre-lunch glucose is below 70, reduce the breakfast insulin by approximately 10 to 20%. If the pre-dinner glucose is below 70, reduce the lunch insulin by approximately 10 to 20%. If the bedtime glucose is below 70, reduce the dinner insulin by approximately 10 to 20%. Adjust the dose responsible for the low glucose pattern rather than automatically reducing every insulin dose. CGM can make these patterns easier to identify and should be incorporated whenever feasible. I've added a 1-hour lecture on CGM and insulin pumps to Easy Endo Prep, covering the practical concepts and board-relevant topics you need to know. You can access it today when you purchase the course. Now let's review hypoglycemia classification. Every insulin user should receive education about hypoglycemia recognition, prevention, and treatment. Family members and caregivers should also be educated when appropriate. Hypoglycemia is classified into 3 levels. Level 1 is a glucose between 54 and 69 milligrams per deciliter. Level 2 is a glucose below 54 milligrams per deciliter. Level 3, or severe hypoglycemia, is defined by altered mental or physical functioning that requires assistance from another person, regardless of the measured glucose level. A glucose below 54 is level 2 hypoglycemia. It is not automatically level 3 unless the person requires assistance. When the patient is awake and able to swallow, treat with rapidly absorbed oral glucose, such as glucose tablets or fruit juice. Recheck the glucose after 15 minutes and repeat treatment if needed. When the patient is unable to swallow, unconscious, or requires assistance, glucagon should be administered by a trained person. Glucagon should be prescribed for insulin users. Family members and caregivers should be trained in how and when to use the specific product that has been prescribed. Ready-to-use preparations are preferred because they reduce the number of steps required during an emergency. Available options include ready-to-use injectable glucagon, dasiglucagon, and intranasal glucagon. Now let's move to premixed insulin. Premixed insulin may be appropriate for selected patients who need basal and prandial insulin coverage but would benefit from a simpler regimen. Advantages include fewer injections and a simpler dosing schedule. Human premixed insulin may also be lower cost. Premixed insulin may improve adherence in patients with consistent meal schedules. It is best suited to patients with predictable meal timing and predictable carbohydrate intake. The limitations are important. Premixed insulin provides less dosing flexibility because the basal and prandial components are combined in a fixed proportion. Changing one component also changes the other. It also has a higher risk of hypoglycemia than a basal-only regimen. Premixed insulin may be less suitable for patients who skip meals, eat at inconsistent times, or have substantial day-to-day variation in carbohydrate intake. When initiating premixed insulin, a starting total daily dose of approximately 0.2 to 0.3 units per kilogram per day may be used. The total dose is generally divided so that 2/3 is administered before breakfast and 1/3 before the evening meal. When converting from basal insulin, estimate the total premixed dose from the patient's current basal insulin requirements and monitor the glucose response carefully. Let's finish with the key clinical principles. Individualize insulin therapy according to patient characteristics, comorbidities, glucose patterns, and treatment burden. Use basal insulin to target fasting hyperglycemia. Add prandial insulin for persistent post-meal hyperglycemia. Avoid overbasalization. When adding prandial insulin, begin with the largest meal and start with 5 units or 10% of the basal dose. Titrate the breakfast dose according to the pre-lunch glucose, the lunch dose according to the pre-dinner glucose, and the dinner dose according to the bedtime glucose. Educate every insulin user about hypoglycemia. Remember that level 2 hypoglycemia is a glucose below 54, while level 3 hypoglycemia requires assistance from another person regardless of the measured glucose. Prescribe glucagon and train the people who may need to use it. Consider premixed insulin for selected patients who need a simpler regimen and have predictable meals. Incorporate CGM whenever feasible, and always prioritize glycemic control while minimizing hypoglycemia. This was another bite-sized episode of Endo in a Bite. If a detail went by too quickly, don't worry. I've prepared the notes for you. Visit www.easyendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam preparation. Remember, stay consistent, and together we'll work through the ACE consensus statement on the algorithm for the management of dyslipidemia, one bite at a time.